Um, so, um, Hello, everybody. Again, I'm going to introduce myself. I'm Cheryl Baggeroer. I'm the lead psychiatrist for the Primary Care Psychiatry Consultation Program. And this is part 2 of the series we have going right now on COVID anxiety relief. So last week we focused on behavioral approaches, which included techniques on validation and normalization in conversations with patients and colleagues, some meta meditation practice, an exercise on diaphragmatic breathing, and some brief lessons on cognitive behavioral therapy. This week, we're going to focus on the psychopharmacological approaches to anxiety treatment. A lot of the focus of today's call is going to be specifically on medications, and our clinical pharmacist, Debbie Pardo, is going to do most of the speaking on that. It will be case focused, but the bulk of the talk will be on medications. We are going to use 4 anxiety cases, common anxiety cases. I'm going to put anxiety in quotes because the last case is actually on PTSD, which looks a lot like anxiety, but technically is not an anxiety diagnosis. And to tie the first part to the second part, we're actually going to start off with a 5-minute talk and exercise on gratitude. And John Rosenberg is going to lead that conversation for the first 5 minutes of the talk. And then I will switch back to a review of how we're going to do the cases. So I'm going to turn it over to John, who looks like he's in the forest somewhere, very relaxing right now. John?
Thanks, Cheryl. So I'm glad to have the opportunity to speak to providers here. And we want to talk briefly just about gratitude practice and how to think about that personally for yourself, as well as how you might use it with patients. And I want to make clear from the beginning that talking about the benefits of gratitude practice, that as we think about this, it's more than just a feel-good activity. That in fact, there's a lot of research done on gratitude practices that show that gratitude practices enhance long-term happiness as someone measured by 10%. I'm not sure how you can quantify that, but that's what they did. It can increase psychological well-being, and studies have shown that. Other studies have shown that gratitude practices can be a protective factor in reducing suicidal ideation in stressed and depressed individuals, which I find kind of interesting as a psychiatrist dealing with lots of depressed and suicidal individuals. Gratitude practices also reduce depressive symptoms, as found in other studies, and they can significantly improve sleep quality. And one other benefit that's been studied is that gratitude practices increase the likelihood of physical activity, otherwise known as exercise. And of course, we know there are many benefits to incorporating exercise for one's health. So what do we mean when we're talking about a gratitude practice? Well, there are many different ways that you can incorporate that into your life or encourage patients to incorporate that. Some people do a gratitude journal where they might enter something on a daily or a weekly basis to talk about things they feel good about or grateful for. It's important in doing that to do whatever works for you without feeling pressured or as if you're somehow failing to not do it right, but to be making notes in the journal. Other people establish sort of a gratitude partner where you might, with a partner at home or a spouse or a friend, on a daily basis even, briefly make contact and share 2 or 3 different things that you're grateful for on that particular day. And it's important to say it out loud, to actually acknowledge it and voice it. Some people use something called a gratitude jar. They might take some jar at home and decorate it in some way and keep some pieces of paper by the jar with a pen. And at various points in the day, just sort of with the thought comes to you, you write something down and put it in the jar, symbolically to collect all the things that you're grateful for in some way. Other people have utilized a gratitude worksheet. And there are some examples of that. If you Google that, you'll find gratitude worksheets that might be available that you could use. There are people who advocate taking a gratitude walk, which is sort of a meditative walk in which you allow yourself to fully be present in your environment and to observe the things you see around you as you walk, and to be taking it all in, to be very focused on nature, the colors of the trees, the sounds that the birds around you make, the smell of the plants, how the ground might feel underneath your feet, and to be experiencing that with a sense of pleasure and gratefulness. There are others who advocate a sort of meditative gratitude reflection, which is sort of a meditative exercise of sitting down and running through a few different dimensions of one's life where you acknowledge and repeat to yourself the things that you might be grateful for. And there's an example. You'll get some handouts from this presentation in a week or so. And in that handout, there will be a guide to doing a gratitude reflection, as well as the list of the other things that I've talked about. So right now, we're going to do a very brief gratitude exercise here, which I'd like to share with you all as part of my community. And there are two reasons to do this. First, I think it's important for us all to experience what it feels like to enter the mind space of acknowledging gratitude. And secondly, it's of value to share this with others in this community as a way of feeling more in community with those around you. So I'm going to start verbally just by mentioning something I feel grateful for. And I'd like to invite you all to contribute a gratitude statement of some form to the chat space, which you can find by moving your cursor to the bottom of the Zoom screen and click on chats. And then you could enter a chat reflection or a chat statement for us all to share. And I'll start by saying that I'm incredibly grateful that my son and daughter-in-law and granddaughter have temporarily relocated from Washington, D.C. to Berkeley. So they're with us actually as part of our close family unit. And we actually get to touch, hold, hug, and be with our granddaughter as well as my son and his wife. I'm tremendously grateful for that. So again, I invite you all to share something you're grateful for in the community share space, and we'll move on to the rest of the presentation. Thank you.
Thank you, John. We're trying to capitalize on the new technology to try a new gratitude practice, which maybe will be on the list somewhere in the future as one of the options of a gratitude chat box. So I think I technically have to mention that there's a disclaimer and learning objective slides in the slide deck. I don't want to make people crazy and flip back between slides, but the learning objectives are the same ones as last week. So now I'm going to move on to the psychopharm part of the talk. So just briefly to set the stage, there's going to be 4 cases. There will be a case on what we call anxiety symptoms that doesn't have a diagnosis, but just general anxiety symptoms that people might be experiencing, the difference between symptoms and a diagnosis, an adjustment disorder with anxious distress, generalized anxiety disorder, and then PTSD. So those are going to be the 4 cases that we'll review. There'll be a very brief case presentation by one of the psychiatrists on our team, and then a short diagnostic discussion. And by short, I mean like 90 seconds. That is not how much time we would expect you to spend thinking about a diagnosis when you see a patient, but we do want to ground the conversations about medications in a thought about what diagnosis you are trying to treat rather than just anxiety symptoms in general. And then we'll switch over to Debbie Pardo, who is going to spend about 7 or 8 minutes talking about the psychopharm options for that particular case presentation. She's not going to go into dosages for any of the meds, with one exception, which is going to be prazosin in the context of the PTSD case. And the reason for that is just it's a lot of material in a short amount of time. We're going to send out handouts that have all the dosages that you would like to know about for each one of the medications that are mentioned. And at the end of the talk, we will have a little bit of time for questions if people have specific questions about dosages for specific medications, but not just what is the dosage range for Zoloft, because you will get that, but like, you know, when can I go over the 20 milligrams of Lexapro given the QTC concern? So some specific ones that will save some time for the end. But you will get more information than you want in the handout. So let's see. So the other thing is we want to approach each case just again for time constraints with 3 assumptions. One is that you've considered some of the behavioral approaches that we talked about in part 1. We always go from most benign to most complicated, or the risk benefit ratio starts to get different as you go up the treatment options. So trying behavioral approaches that we suggested, that also psychotherapy has been considered. So either a patient's in therapy, they're in the process of getting referred to therapy, or they're actually just declining psychotherapy, but you have offered that to them, because all of the diagnoses that we're talking about can respond to psychotherapy in some positive way, but we have a lot of patients that cannot or will not go to therapy. So we recognize that. And then the third options is that pharmacological approaches that have been tried, we have this backwards. The non-pharmacological approaches have been unsuccessful, or the symptoms are so severe that you need to do both right out of the gate, or that the pharmacological treatments that you have used, you need to be getting more complex recommendations. So those are the assumptions for each one of the cases. Sorry, I'm having a little trouble with this slide. So here's case 1. I'm going to turn this over to Madeleine Lansky, who's going to do the case presentation and the diagnostic discussion, and then she'll turn it over to Debbie. Madeleine?
Hi. So the first case is a 52-year-old male who finds himself reading news and worrying about the protests and the pandemic all the time. One of his cousins had COVID-19 and recovered, but he worried what will happen if he gets sick, particularly because he has diabetes. Maybe you could hold the mouse steady. He denies prior mental health history, though he thinks he worries more than some of his friends do at this time. And he's been smoking cannabis most days and at night for sleep, but he also did so before the pandemic started. And he denies any other substance use, including alcohol. So we might have met several people like this, and one way to really get this kind of case into focus is to distinguish if this guy is dealing with anxiety symptoms or an anxiety diagnosis. And one of the ways you start to distinguish that is to go through the acuity and the quantity of the symptoms, really looking at the DSM to see if criteria are fulfilled, the duration of the symptoms, and the degree of impairment, if it's affecting work and home life. You're also looking for impact of the substance use, assessing the usage. Is this person using controlled substances, possibly things being prescribed by you, or uncontrolled or unmonitored substances, be they legal like cannabis or alcohol, or illegal like opiates? And consider possible withdrawal syndromes from all of these possible substances, both controlled and uncontrolled. You're also looking into the impact of sleep disturbance, because sleep impacts so many aspects of our lives. So looking at the duration of a sleep disturbance and what type. You can get at this by going into sleep onset, finding out about awakenings, as well as early morning awakenings. And with this, what you're trying to do with sleep is to rule out or address medical causes of sleep disturbance, like sleep apnea, restless leg syndrome, thyroid dysfunction, caffeine intake, iatrogenic, or other causes that could be addressed medically before moving on to a deeper psychiatric inquiry.
So Debbie, you want to take over from here?
Madeleine's going to talk a little bit about some herbal products first. Who's advancing the slides? Do you have control of that?
I do.
Okay.
Okay. So I want to just quickly talk about some non-pharmacologic treatment approaches for sleep disturbance. Debbie's going to take up the pharmacologic piece, and I'm not going to be necessarily talking about an evidence-based model here. This is anecdotal, what I've heard from my patients, what I've heard from friends and family, how I got through med school. So these are things that shouldn't interact too much with other medications. And I think the biggest risk to them is that you waste money on them and they don't do anything. So you should still consider a need for medical workup, still do a really proper psychiatric evaluation, incorporate sleep hygiene, incorporate behavioral approaches like meditation, relaxation exercises, and CBT for insomnia really is the gold standard. There actually is an app called CBTI that patients can download to do it for themselves. And then here are some products I've noticed can be helpful. Celestial Seasonings makes 2 teas. One is called Sleepy Time and the other is called Tension Tamer, and they are quite soporific or sedating. There are homeopathic remedies. Specifically, these are little white pellets that come in these little blue canisters, and you open it up by twisting in a certain way and put 5 pellets under your tongue sublingually. And it's called coffee cruda. And actually the theory with homeopathy is that it's 1/1 millionth of whatever makes the symptom treats the symptom. So it's 1/1 millionth of coffee. Boss flower essences can be helpful. They are suspended in alcohol, so heads up with that, but patients can allow it to gas off for a couple minutes in water and the alcohol will go away. But rescue sleep is something that can be sprayed under the tongue. It's kind of a cousin to rescue remedy, which is a surprisingly good anxiety remedy that I truly started to believe in when I started using it for dogs going on planes. They didn't fall asleep, but they were just relaxed. Magnesium improves sleep onset, and melatonin can be helpful. Debbie's going to go more into melatonin, but I'll say quickly about liquid melatonin that there's ways to work with it to keep the dosages more in the microgram range than the milligram range. There's evidence, at least with kids, that even in the microgram range, it can be helpful. And some of the pharmacies and some of the FQHCs are getting it on formulary now, make some very inexpensive products, but you can have patients put 1 drop sublingually at about 4 or 5 p.m. to cue the brain that sundown is approaching, and then begin with about 0.5 milligram to see if that initiates sleep, and they can build up drop by drop so that they can keep the doses low but still get a beneficial effect. And I'll leave the next steps to Debbie.
Yeah, in situations where all of the interventions that Madeleine just talked about aren't enough or where symptoms are severe, there's multiple medication options that we can consider to be used in combination with a lot of those behavioral approaches. And the American Academy of Sleep Medicine recommends limiting the use of these short-term sleep options to 90 days. And that's even in those with a formal diagnosis of chronic insomnia. Medication choice should be based on the nature of the sleep disturbance. So is the patient reporting difficulty falling asleep, staying asleep, both? And then other patient-specific factors such as comorbidities, age, prior treatment and response, and drug interactions should also guide the medication choice here. The recommended dose ranges, as we mentioned, and also the maximum doses will be given in the handout that will supplement this presentation. For most patients, the first thing that we typically try is one of the sedating antihistamines such as Benadryl, diphenhydramine, hydroxyzine, or doxylamine, which is one of the active ingredients in some of the Unisom over-the-counter products. And these medications can be used as needed. They improve both sleep onset and sleep maintenance. It's important to keep in mind, though, that sedating antihistamines should be avoided in elderly patients, those with dementia, or those that are prescribed other anticholinergic medications. And for those patient populations, melatonin is considered a safer alternative, and the Beers criteria recommends melatonin for those populations. Melatonin can be used as needed or on a scheduled basis. It tends to be more effective for sleep onset rather than sleep maintenance. And then after a trial of these sedating antihistamines or melatonin, we can consider other medications, and the choice of those is usually guided by comorbidities. So other medications could be TCAs, trazodone, gabapentin, or mirtazapine. Generally, as-needed dosing is used for sleep, but if you're using these medications for another comorbidity like depression or pain, scheduled dosing may be required to achieve results for those comorbidities. Low-dose TCAs, specifically doxepin and amitriptyline, may be used as needed or on a scheduled basis for sleep onset and sleep maintenance. Amitriptyline may be particularly helpful in those that have comorbid pain diagnoses or depressive symptoms, but it's important to note that neither doxepin or amitriptyline or any TCAs really should be used in elderly patients, those with dementia, or those on anticholinergic medications because of the potential for additive anticholinergic effects. The antidepressant trazodone may be used as needed or on a scheduled basis to improve sleep onset and maintenance, and may be particularly helpful in those who have depressive symptoms. Both trazodone and amitriptyline block alpha-1 receptors, so they carry a risk of orthostasis, especially with intermittent dosing, which would be the case if you're using it as needed. In patients with alcohol or cannabis use disorder, there is some evidence to support the use of gabapentin for sleep disturbance if it's related to alcohol or cannabis withdrawal or cravings. But it's important also to keep in mind that there are emerging reports of abuse potential with gabapentin, so a discussion of alcohol or cannabis tapering or discontinuation should be part of your treatment plan if you're going to be using gabapentin for this indication. Gabapentin may also be helpful for sleep in those who have a diagnosis of pain, and in those cases, scheduled dosing might be more helpful if you want to try to conquer both of those conditions. In patients that have comorbid depression, PTSD, or sleep disturbance related to cannabis withdrawal, mirtazapine may be helpful for sleep onset and sleep quality. For best results, mirtazapine should be used on a scheduled basis and at low doses because it tends to be more sedating at low doses than high doses. And lastly, benzos or Z drugs should generally be avoided, especially in elderly patients and those with a past or current substance use. For some patients, tapering or discontinuing cannabis may be part of the treatment plan for managing anxiety or sleep. And in this case, it's important to consider that treatment options for cannabis withdrawal or symptoms of cannabis withdrawal could include things like sleep disturbance, anxiety, irritability, decreased appetite, decreased mood, cravings, and physical symptoms like tremors, body aches, headaches. And cannabis withdrawal symptoms can happen within 48 hours of stopping cannabis and can continue for up to 4 to 12 weeks. Psychosocial interventions like CBT and behavioral modifications are considered first line, but there are some medication options that have either weak or inconsistent data to support their use. And those options would be gabapentin, mirtazapine, N-acetylcysteine, naltrexone, and quetiapine and topiramate. And I'll put some details on the handout that we'll provide about when these might be more useful. So next we'll go on to case 2.
Okay, all right. So Jerry Nyo is going to present case 2 in the discussion on case 2. So Jerry.
Thanks, everybody. Hi, I'm grateful to be here and to give this presentation. So case 2, adjustment disorder with anxious distress. So this is a 32-year-old female, presents with insomnia starting with the shelter-in-place order. She's had symptoms of anxiety that began in the early 20s following a breakup, but those resolved within a few months. She's been worrying all the time about everything, including her health, her family's health, the possibility of transmitting COVID to somebody else, losing her job, housing. The recent protests that have been going on have made her worry that a second wave is coming, and so she's afraid to leave her house. She's tired, she's exhausted from worrying all day, but she is able to fall asleep easily, but then she wakes up after 3 hours and is unable to go back to sleep. There's no alcohol. This appears to make her insomnia worse, and she's used cannabis in the past, but this made her paranoid, so she decided to stop. There are no other substances.
I'm sorry, I apologize. The screen advancement is not working on my end very well.
So in thinking about the differential diagnosis for this, sort of the two disorders that come up are adjustment disorder versus generalized anxiety disorder. Some of the factors that can help you sort of distinguish the diagnosis is, for instance, the identification of a stressor. we know that with an adjustment disorder, you have to have a particular stressor that results in distress. Generalized anxiety disorder, people are sort of generally anxious about a lot of different things. The other question I oftentimes like to ask is, would this person's symptoms subside if the stressor was no longer present, if the stressor resolved? And if the stressor goes away and the symptoms go away, then you're looking much more towards an adjustment disorder. There's a lot of different types of stressors that you can have. DSM lists, the actual DSM text lists several, including things such as seasonal business crises, unfulfilled sexual relationships, painful, persistent illness. Even living in a crime-ridden neighborhood is actually listed as a stressor as well too. So other things you want to consider is the length of time that the person's had the symptoms. So by definition, for an adjustment disorder, you have to have the onset of symptoms within 3 months. For a generalized anxiety disorder, the symptoms need to persist for greater than 6 months to meet the criteria for the diagnosis. We also want to look at the intensity of the symptoms and the degree of functional impairment. I'd say, generally speaking, the generalized anxiety disorder is associated with greater severity of functional impairment and symptoms. An adjustment disorder tends to be a little bit less. And then also looking at the type of, if there's any mood symptoms that come along, because generalized anxiety disorder, primarily the mood is a very anxious type of mood. With adjustment disorders, there's different types, as I'll go through a few right here. There's adjustment disorders with anxiety, with depressed mood. You can have a combination of the two, anxiety and depressed mood. You can have disturbance of conducts, and you can also have the mixed disturbance of mood and conduct, where you see behavioral issues as well. So again, if somebody's having sort of other symptoms of, again, depressed mood, then that might make you lean a little bit more towards an adjustment disorder.
Thanks, Jerry.
Mm-hmm.
Non-medication interventions such as psychotherapy and behavioral approaches are considered first-line treatment for adjustment disorder, mostly because there's limited evidence that talk about any effective pharmacologic treatments for adjustment disorder. So it can be helpful to gather information from the patient about their personal or family experience with psychiatric medications to help make a decision about a medication for this particular case. Generally, the medications that may improve symptoms of adjustment disorder include SSRIs, SNRIs, mirtazapine, or buspirone. To guide drug selection, it can also be helpful to consider the patient's most prominent symptoms. So in this particular case where anxiety is a prominent symptom, it may be reasonable to consider an SSRI, an SNRI, or buspirone first. If depressive symptoms are prominent, you could consider an SSRI, SNRI, or mirtazapine first. And then if sleep disturbance is the prominent symptom, you might consider mirtazapine first because of its sedating effects. Any of these medication options for adjustment disorder should be started at low doses and titrated slowly to minimize side effects. It can take 4 to 6 weeks at therapeutic doses for a patient to notice the full effects of these medications. And because of this delay, short-term use, which we define throughout this presentation as about 90 days, of an as-needed medication can be offered as adjunct for either breakthrough anxiety or sleep symptoms. Although some patients taking buspirone as an as-needed medication may report benefit from using it this way, the best results are achieved by using buspirone on a scheduled basis, usually divided twice daily or 3 times a day. The reason for this is that buspirone works by modulating serotonin neurotransmission, which leads to a cascade of cellular changes and eventually affects what receptors are expressed on the cell and affects the neurotransmission of serotonin. And these changes don't happen overnight. They can take 4 to 6 weeks to occur, which is why immediate anxiolytic effects from buspirone are not expected. But some patients do say that it has a sedating effect, so that particular side effect may provide temporary anxiolytic effect, but it is not the main mechanism by which buspirone is thought to improve anxiety. Lastly, it may be best to avoid Wellbutrin or bupropion in patients with prominent anxiety symptoms because Wellbutrin enhances norepinephrine and dopamine neurotransmission, which tend to be more activating. And this can exacerbate anxiety symptoms. So bupropion or Wellbutrin may be something to avoid in someone with adjustment disorder with anxious symptoms. Because there may be this delay in the onset of the effects of either SSRIs, SNRIs, mirtazapine, or buspirone, an as-needed medication can be used for anxiety symptoms until the maintenance medication starts working. As-needed medications can also be offered to patients who aren't interested in a daily medication, or in those who are already on a daily medication or maintenance regimen and are having breakthrough symptoms. One common non-benzo medication that is offered as needed for anxiety is the sedating antihistamine hydroxyzine. For patients that experience somatic or physical manifestations of anxiety, such as chest palpitations, trembling or tremors, or sweating, low-dose propranolol can be effective for those particular anxiety symptoms. For patients that experience worsened anxiety in the context of cannabis or alcohol withdrawal or tapering, gabapentin could be used as needed for anxiety symptoms. And the medication options we reviewed from the first case for sleep can also be used here in someone with adjustment disorder who has prominent sleep disturbance. And then, as we talked about in the first case, benzos should be avoided in adjustment disorder, especially if there's current or past substance use. Next case.
Okay, so the next case, Karen Chiu is going to present the case in the discussion. Karen?
Hey, thank you, Cheryl. So case 3 is generalized anxiety disorder. So this is similar to case 2, except that this patient has a prior diagnosis. So this lady is a 42-year-old lady with a prior diagnosis of generalized anxiety disorder. She has been stable for the last 5 years. When she was symptomatic in the past, when she was first diagnosed, her symptoms included she couldn't control her worrying, she had trouble concentrating, and also had some trouble sleeping. She felt very irritable and exhausted all the time. The medication she was started on and titrated up on was escitalopram or Lexapro, and she was eventually stabilized on 20 milligrams daily. She's been on it for the past 6 years with minimal side effects. However, after the pandemic started, she started worrying all the time about the safety of her older parents. She has not been working, and she fears being laid off. She developed some trouble sleeping, and she finds herself crying easily. She does use alcohol a few times a week, but denies other substances, including cannabis, doesn't have a history of medical issues or other substance use. So for the diagnostic discussion of this case, this lady definitely did meet the criteria for generalized anxiety disorder, which you see here. This is just straight from the DSM-5. However, she also has an anxiety flare because of the recent pandemic. So the criteria include, the criteria for generalized anxiety disorder includes excessive worrying, more days than not, about a number of events. So these patients are worried about many different things across like a variety of settings. They have to have these symptoms for at least 6 months, and they also have to have difficulty controlling the worry. They have at least three out of 6 symptoms, which include feeling restless or on edge, being easily fatigued, having difficulty concentrating, irritability, muscle tension, and sleep disturbance. So these overlap with some other psychiatric symptoms too, so it's important to look at the big picture. And certainly these criteria sound like what a lot of people are experiencing nowadays, but it's also important to see if there's a functional impairment. So if this person is having difficulty at work, at school, relationships, family, and various things like that. So that's absolutely essential to make the diagnosis. So the incidence is roughly about 3% in the past year and roughly about 6% over the lifetime. And the demographics, so generalized anxiety disorder typically affects females a lot more than males. So we've seen it range somewhere between 2 to 3 females for every 1 male. So I'm going to turn over to Debbie now for a discussion about the medications.
First-line medication treatment for generalized anxiety disorder is usually SSRIs or SNRIs. And in this case, the patient was previously stable on their SSRI Lexapro, but has developed worsened anxiety or breakthrough anxiety. The first option to consider in this case is whether the dose of their current medication can be increased before we consider adding alternative medications or switching medications. So this patient happens to already be prescribed the maximum recommended dose of Lexapro. There are certain SSRIs or SNRIs where there is evidence to support exceeding the recommended max dose, and the details about that will be provided in the supplemental handouts, but Lexapro is not one of these medications, so increasing the dose of her current medication is not an option here. If possible, we want to avoid switching the current SSRI or SNRI to a different one in the context of a new stressor, especially if the patient has demonstrated a response or remission on the current regimen. So our next option would be to consider augmenting the current therapy by adding either buspirone or a TCA. When using buspirone as an augmenting agent, such as would be considered in this case, best results are achieved with scheduled dosing, usually twice a day or 3 times a day. For patients who find buspirone sedating or who have trouble taking it multiple times a day, you could consider once daily dosing or possibly once daily at bedtime if they find it sedating. But the key is that scheduled doses produce the best effects rather than PRN dosing. As we talked about before, because of the sedating effect, they may have some acute anxiety relief, but it usually takes about 4 to 6 weeks of scheduled therapeutic dosing to see full effects from buspirone. Buspirone is typically well tolerated. It tends to be more well tolerated than SSRIs, SNRIs, or TCAs. But in patients who have a comorbid pain diagnosis, you may consider using a TCA over buspirone, and the specific TCAs you might consider would be amitriptyline or nortriptyline, as these could be helpful for addressing both the pain and the anxiety. The antihistamine effects from TCAs are obviously sedating and may provide immediate or temporary anxiety relief. But if you're using a low-dose TCA on a scheduled basis to augment an SSRI or SNRI, it usually takes about 4 to 6 weeks of scheduled dosing to see full effects for anxiety. I think longer for pain. Because these augmenting agents have a delayed onset, we can consider the short-term use of as-needed medications either for sleep or anxiety, and those are the same options that we discussed in the first 2 cases.
So now we're going to go on to the final case. John's going to talk about post-traumatic stress disorder, which I mentioned at the beginning is not an anxiety disorder, but we are seeing a lot of people have exacerbations of pre-existing PTSD diagnoses. So we wanted to touch on medications for that in the context of this talk. John?
Thanks. So the case I want to talk about is that of a 65-year-old woman who comes in describing an extensive trauma history. However, she had previously been stable for many years on fluoxetine 40 milligrams and trazodone 100 milligrams at night. In the current context, however, she's found herself very stressed by issues related to the pandemic. She's had to assume care for some other family members in a very significant way, and then exposure to the news and reading about others' family losses, as well as other significant events and going on in the community have led her to sort of be aware of pain and suffering that other people experience in a way that's gotten her anxiety level heightened. And she's now describing an increase in nightmares that have recurred after many years of absence. She occasionally is hearing some auditory hallucinations, which she had experienced in the past. She's been very apprehensive about her own personal safety and safety of her family members around her. And she's noticing that she has less of an interest in activities in the community, and an increase in anxiety and a startled response when she hears buses roaring by the place where she lives. She's reporting that because of all this, she ends up feeling on edge and tense all the time and somewhat irritable and finding herself not wanting to interact with people. And in terms of the diagnosis of PTSD, this is a syndrome that occurs for more than a month. Less than a month would be called an acute stress disorder. And people with PTSD are those who have been exposed to trauma, and they have a variety of symptoms. The DSM breaks those up into intrusion, avoidance, negative cognition and mood symptoms, and arousal and reactivity symptoms. And you have to have a certain number of symptoms within those 4 baskets in order to qualify for the diagnosis. 1 intrusion symptom, 1 avoidance symptom, 2 negative cognition or mood symptoms, and 2 arousal or reactivity symptoms. This can be a new onset of PTSD, but in this case, for example, what we're seeing is someone who previously was diagnosed and treated successfully for PTSD, but related to the stresses of the moment is having an exacerbation of the pre-existing diagnostic condition. There's also a condition called complex PTSD, which I won't go into. It's not defined in DSM-5, but it is identified in the ICD-11. And this is usually related to chronic, ongoing, multiple, repeated events of trauma that occur in certain settings, and has some overlap with PTSD symptoms.
So first line medication treatment for PTSD is SSRIs or SNRIs. More specifically, guidelines recommend sertraline, paroxetine, fluoxetine, or venlafaxine first. This patient's already prescribed the SSRI fluoxetine. So similar to the last case, we first want to see whether there's room to increase the dose of the patient's current medications before we consider adding other medications or switching to something else. Doses of fluoxetine up to 80 milligrams have been used in PTSD, but the usual target range is about 20 to 60 milligrams. In this case, increasing fluoxetine would be probably the first thing to try. And similar to our approach with generalized anxiety disorder in the previous case, we want to try to avoid switching to a completely different SSRI or SNRI if the patient hasn't tried the max dose of the current one, and especially in the context of new stressors, since they seem to have had a response to the current medication in the past. The effects of increasing the fluoxetine can be delayed 4 to 6 weeks, so we could consider short-term use of an as-needed medication, and those options would be the same ones as discussed in case 2. The approach for sleep disturbance here in PTSD is similar in that we want to try to optimize what the patient is currently on before we switch to something new. So this patient's already prescribed trazodone and they're taking it on a scheduled basis at nighttime. We could consider increasing the dose up to 200 milligrams for sleep. But if the patient is using trazodone as needed, lower target doses such as 50 milligrams are recommended because of the risk of orthostasis with intermittent dosing. If we try the maximum dose of the current medication and it doesn't seem to be controlling the symptoms, we could consider switching to an alternative sleep medication, and those options would be the ones that we discussed in case 1. To minimize the risk of polypharmacy and other things like serotonin syndrome and additive side effects, we want to try to discontinue any medications that are deemed to be not effective instead of adding on to the current medication regimen. For this particular case, the patient is reporting trauma-related nightmares, so we could consider offering them a trial of prazosin. And for safety and also efficacy purposes, prazosin should be used on a scheduled basis only, and the typical dose range is between 1 to 10 milligrams every night. But prazosin should always be started at 1 milligram, and then we can titrate slowly every couple of days or as tolerated in 1 to 2 milligram increments. If prazosin therapy is interrupted for longer than 48 hours, we do need to retitrate it because of this risk of orthostasis. And for this particular case, it's important to note that a lot of guidelines consider benzos relatively contraindicated in PTSD, and so we would want to avoid those in this case. Some PTSD treatment guidelines and also the current data generally don't support the routine use of antipsychotics as monotherapy for PTSD. There's limited data supporting the use of antipsychotics to augment specific symptoms in PTSD. For example, antipsychotics may be used for treatment-resistant psychotic symptoms in PTSD, Aripiprazole may be used for depressive symptoms as an adjunct to antidepressants, is similar to how we would use it for treatment-resistant depression. Quetiapine could be used for short-term management of nighttime symptoms or insomnia and PTSD, but it's recommended to limit the prescribing of quetiapine for this purpose for 9 to 90 days because of the long-term risks associated with it. There are some studies that show that risperidone can improve re-experiencing and hyperarousal symptoms. For this particular case, the patient is reporting auditory hallucinations, for which we could consider a trial of an antipsychotic medication, such as a short course of quetiapine, which may also help with sleep. But aside from having limited evidence, another reason why we reserve antipsychotics as sort of a last resort or limit the use to short courses, especially in PTSD, is because antipsychotics carry long-term risks such as metabolic syndrome, movement disorders like tardive dyskinesia, and hyperprolactinemia. All of these things require ongoing monitoring. So when using antipsychotics, we need to be sure that we're doing regular assessments of the risks and benefits and the appropriateness of continued use. And this is to minimize the long-term adverse effects, but also any side effects that can emerge.
So that's it for the cases. And I think Debbie's going to wrap it up briefly, and then we'll have some time for questions.
Sure. Yeah, so just to kind of summarize what we talked about today, stressors related to COVID can contribute to new or worsened psychiatric symptoms, and this may come up in the form of anxiety or sleep disturbance. Generally, we want to try non-medication interventions and behavioral approaches first before we consider offering medications. And if applicable, we want to incorporate discussions of substance use and talk about maybe tapering or discontinuing substances if it seems like that could be contributing to the psychiatric symptoms. If non-pharmacologic strategies are not enough or symptoms are severe, we can consider offering medication treatments. So some main points for these medication treatments would be to optimize whatever the patient is currently on if they're on something before switching to something new or adding something else. We want to try to taper or discontinue any medications that seem to be not working to avoid polypharmacy. Limit the use of as-needed medications to short-term use, which we consider to be about 90 days. And then avoid benzos for stressor or trauma-related symptoms, as would be the case for the cases we talked about today, especially if there's current or past substance use.
Thank you, Debbie. I know that we just gave a lot of information really fast, so we could probably do this over 4 talks, but wanted to try to touch on a lot of things with this hour. So we have about almost 10 minutes for questions related to specific cases or specific medication usages. And again, we'll have handouts that will have a lot of the more detailed content about dosages and when you can go over the dosages and how to do cross tapers and things like that with the feedback in the next week or 2. So expect that with the talk. Anybody, you can either just unmute yourself or you can put it in the chat and let me know.
So I am seeing 2 questions already there in the chat.
Okay, sorry, I couldn't see the chat while I was sharing the screen. So John, you want to lead with them since you can see them?
It looks like Jean Marsters has asked, what doses do you consider low for amitriptyline with respect to not being concerned about serotonin syndrome? Debbie, you want to take that?
I can talk about that first. So to answering that probably depends on what other medications the patient is on. If they're already on like 1 or 2 other serotonergic medications, I would probably not recommend more than like 50 milligrams of a TCA. There's also the potential for drug interactions with some of the CYP enzymes. So I would have to take that, into consideration as well. But I would probably say just generally low dose, I would consider to be 50 milligrams or less per day.
And another question from Jean also, of the antipsychotics, which has the lowest cardiac side effect profile?
It depends what kind of cardiac concerns you're referring to, but if we're thinking about something like QTC prolongation, then Abilify has the lowest risk of affecting QTC. If we're thinking about cardiac risks that come from the metabolic syndrome piece of it, then obviously the medications that have high metabolic risk will have high cardiac risk. But again, Abilify would probably be on the safer side in that respect as well.
And then Jean has another question. Jean, I'm not sure if you're able to unmute yourself and if you want to ask this next question yourself. Hello? Not hearing from Jean. Debbie, can you read the question? Or do you see it there? Actually, there's a question for everybody, it would seem. And Jean says, I'm seeing a lot of patients during shelter in place who are having soft psychotic symptoms like hearing their name called or hearing noises in the building. I guess it's 50% of my patients with a variety of diagnoses. Are others seeing this?
I can speak to the consults that I'm getting, which is that I'm not sure it's 50%, but I do think that there are, I am hearing more soft psychotic symptoms, particularly in people with pre-existing PTSD diagnoses. So I don't know about other people on our team or any of the other PCPs.
Other team members?
So I would say that usually those soft psychotic symptoms, I always call those like sort of like misperceptions. They're not really exactly the same as auditory hallucinations. And we do see that in people with PTSD flares, and it happens a lot at night. They think they hear someone calling for help or hear their name being called or the phone ringing or the doorbell ringing or something like that. But they're very, very brief and they're not like directed conversations. So very different than the hallucinations you would see in like a schizophrenic patient. I think it's related to severe anxiety and maybe also like some sleep disturbance too.
I can suggest a question that comes up a lot in consults that maybe Debbie, you can speak to is, we do use hydroxyzine a lot as a PRN medication. And then people also are on Celexa and Lexapro for their anxiety diagnoses. And there seems to be an increase in pharmacy warnings about prescribing the two together in terms of the QT prolongation. And the question would be, how do you address that in terms of the dosages, given that, you know, the warning is going to come up? Would you avoid it? Can you speak to that a little bit?
Sure. I mean, those pop up as class warnings, but the biggest concern obviously would be with the SSRIs that have the highest QTC risk, which first would be Celexa, and then Lexapro often gets associated with that, even though the risk is lower. And the data for hydroxyzine QTC prolongation is that it is dose related, and a lot of the studies that showed the QTC prolongation was at high doses like 200 to 400 milligrams. So if, as long as the dose is low of hydroxyzine, like 100 or less per day, and there are no other comorbidities that could increase the risk for QTC prolongation, it's still something to watch out for and monitor, but it's not a contraindication to using them together.
I think one of the things that's coming up is it's much harder to get a EKG on somebody that you'd like to kind of keep the doses on the higher end of the normal range. So I think just sounds like be cautious about it, reduce it if you can, try not to go over 100, and be careful of other meds.
Yeah.
Any other last minute questions? Samira sent a link to the survey. Do feel free to put in the evaluation survey specific things that you want included on the handouts. We're trying to be like last week we got a lot of requests for different languages of some of the exercises, and so that's one of the things we're trying to find out if we can get included. So other specific things that you want to make sure you have a reference source for. So huge thanks to Debbie for doing most of the talking for this talk, and thanks to everybody for taking their lunch hour to come and learn more about psychiatric medications. I think this is a long game because we're going to get more and more of this by everybody's reports over the next year or so. So we are trying to get as much information out to providers as possible, and are open to doing more of this in the future if people want to give some feedback on what they would like to learn about. So thank you, everybody. Have a good rest of your day.
Thank you.